That's your information right there. Did everyone see where the playground is, the pinkish one? Okay. On the bottom of your page that's sitting in front of you is a little name and number. The I number, go ahead and put that in as your username when you get to the playground. Okay? Yeah, the playground on the right. And then everyone's password is the same. It's train, T-R-A-I-N. Yep, your IP number. Okay. And if you look at the bottom, you have a name attached to yours. Up in this section up here, like where it says, you're not actually at this screen, but you've got a search engine up there. Put your last name in.
They're in New Epic. So
this name or
What?
this name?
Oh.
Where she put it?
Again. What is all this screen happening?
it's New Epic. Coming to a real epic
this
near
is
you.
the COI playground environment created on Tuesday via environment and coverage.
Okay, yeah, go ahead.
And then I moved to the same today.
Why does it say rain?
They're on the,
That's the first screen now.
That's the news, yeah.
Okay, so where do we put their names in?
So
The patient names.
So
I just
I can do,
picked whoever showed up.
yeah, so I can sign in for 12 hours.
Okay.
And then I will just,
You gotta pick a unit down below, so press add.
let's see here.
Pick
Pick
SICU.
whatever unit.
Got it.
SICU's the best unit. It has the most patients in it.
Okay, and then just so I don't have any patients to sign.
Okay. So try to find this last name here.
Can we sign them with our information?
Okay. Try to. Okay. I just pick a name. So
I can also, maybe, can I
I don't see a
cancel
search
out of
form.
this? I can search it, right?
That's how
Okay.
you select
Okay.
assignment today, and then you're
Oh,
automatically.
gosh.
Oh, it's because you have that weird.
All right. We're gonna do. So let's see where everyone's at. Okay. You are the first name. You're the second name. Third. 4, 5,
I don't know how to get back onto it.
6, 7. Okay.
So this is the new version that's gonna show up with New Epic. Your banana?
There we go. Okay. So try to go to your
I don't have
lookup.
Cindy though.
That's okay. I don't care about the first name. It's the last name I care about. So if you guys can go to patient lookup.
It should be.
Oh, you got a patient? You have. That's fine.
That's good.
Who do you have? I have Pablo Apricot. Okay, go for it. Does anybody have apricot? Okay, you got apricot?
I got banana.
You got banana? Just click his name.
Cantabria.
What do you got?
Cantabria.
Bria? Oh, Cantabria. Anybody got Cantabria? Yours.
I got bayberry and black cherry.
Black cherry, bayberry.
If you just don't click on it.
Okay.
Open their chart like we're used to
And you got a different one. You can just use that one. Click over his name.
I think I look like her though.
There we go.
No, that's all the.
Yours is an outpatient.
It started flaking last night.
Yours is an outpatient.
It's cool. I did other. I do a portfolio.
Apple. Does anybody have
class,
apple?
Teacher orientation.
Oh, okay. Apple's yours.
Advanced.
Apples are good. All right, everyone got a patient up now? Okay. So, good morning.
Good morning.
My name is Tiffany. I'm one of the rapid response nurses in the adult world. So we're going to just go over some quick documentation for code documentation, and then you all have a scenario that you're going to go over on your own. This is education. It is not actually a validation. It's mandatory education this year. Has anybody ever had a rapid? or a code? They're very scary, they're kind of scary, so, but as a documenter, all I want you to really do is focus on the documentation. When you call a code, there's gonna be a million people that show up, right? We're trying to decrease that number by going silent. We don't have them overhead anymore, and it has helped a little, but no, it's something that you're gonna have a lot of people showing up to. But as a documenter, all I want you to worry about is focusing on that document. That means you are not the runner, that means you are not the timekeeper. Okay, you are not passing meds. You're not giving advice unless you really feel strongly about it. Just try to concentrate on that document, okay? So if everyone everyone got something that looks like this? Right now I'm just going to show you, I don't want you documenting yet. I'm just gonna kind of go through this little scenario so you can see what you're doing, and then I want you to do your own that's on your table. Okay, so when you pull up your patient, everyone gets their own wow. You shouldn't be sharing your wow with your doctors. They all want to come down and be like, hey, can I just put that order in? No. Okay? They have 2 computers in the room for a reason. They can have one, you can have one. So this is the screen. On the left-hand side of your screen on your favorites bar, on the bottom is more activities. When you hit the more activities button, it's going to bring up this screen, and there's code documentation here. When you go back into your real world, one of the things you can do to save yourself a step in the future is click this little arrow or this star, and it'll turn yellow. It'll become a part of your favorites bar forever and ever until Epic upgrades again. Okay? When you open that document, this is what you're going to see. We're going to hit code for us today. There's 2 different ways you can get vital signs in. We do not suggest you use this middle bar. It looks really convenient, however, what's not convenient is you can't change the time. So whatever time you're using, it's going to automatically attach to that time stamp. With code documentation, we need to be very specific, so we want you to make sure you're not using this. Over here, on the right-hand side of your screen is going to be a vital signs button. Whether you're in a rapid or code, there's a vital signs button. This side of the screen is your flow sheet. This side of the screen is your MAR. Anything you do in this document will automatically show up in your real chart. So you don't have to go back and document. It'll automatically push to the right spot. Okay? We want you to expand all, so there's going to be this, and then underneath here is rapid. It'll open up just as much as this. We only want you to have the code document open today, just because then you're not intermixing the 2. Makes it a little bit easier. The 4 things you absolutely have to have for documenting is your code start. That's the front of your book. The code end is the end of your book. In between, you want the onset, which is like your glossary or not your table of contents. And that onset tells us why you're calling the rapid. What happened. The outcome is what happened at the end. So that's your glossary. Okay, so we want to know here, did you go to a procedure? Did you transfer to a higher level of care? Did your patient pass away?
Is that all in basically typed? Just typed
No.
in note, or-
No, we very little do you have to actually write.
Okay.
It's mostly click.
So there's an other in case it doesn't fit into one of the standards.
Mhm.
Okay.
Yep. This is what I just told you about minimizing. So what happens when you don't see those code blue button? It means your patient's probably sicker. What that means is that your patient has already had a code or a rapid, and when you hit the expand all button, like we just talked about back here, there is a second way that you can hit a code start. So if this has already got a document in it because your patient's had an event before, you can get a fresh sheet of paper by hitting this code start. We don't want you to interchange. Unfortunately, we couldn't do 2 different documents because it's way too much for Epic and so much of the same information. Just know if you're doing a code that you're sticking under code document. If you're doing a rapid, you stick under rapid document.
And so if you have a rapid that goes to a code, then you begin and end that rapid as soon as your code starts.
That's a great question. It's actually no.
Okay.
Think about it, go back to our book scenario, it's a second chapter. So we don't want you to end it because it takes that piece of paper away. We want a second chapter as to what happened with that patient. So your outcome that we had talked about would be a code blue. You do
Okay.
not end it, because when you end the code, it'll end both.
Okay.
But that's a great question. It makes it easier when we do go through and do deep dives that we don't have two separate documents. Okay, your onset is what happened. Why did the, what happened that you're calling this? Did the patient go agonal, apnea, unconscious, pulseless? Again, this is your flow sheet side and your medication side, so that's your MAR. We had the ACLS drugs at the top on purpose. At the bottom, the lower you get down, the more you're going to see your patient's MAR. So if you have racemic epi for that patient, it'll be down at the bottom. Only up here is the ACLS drugs, and then we have some infusion stuff. You can always add in, that's a little bit farther down, you can actually add in a drug just as if you were adding a drug, but these are what we felt was the most important drugs, and the ACLS drugs, of course. In the code documentation, the button that we're going to use the most is code intervention. Code intervention tells us, we can defibrillate under that button, we can do compressions, we can do cardioversion, pulse check, rhythm check, which is going to be your mainstay throughout the whole code. If you've ever had a rapid response, there's all different places you can do things. Code is a little bit simpler, even though it's a lot more stressful, because really you do compressions, you do a pulse check, you give one med. You do a compression, maybe you defibrillate, you give another med. So it's very actually regimented versus rapids can be a little bit more, there's a lot more you can do in a rapid. So one of the things that we're missing as an institution is starting compressions in documentation. We know that when you go in the morning and find your patient without a pulse, you're starting compressions, right? We're not documenting it. So as a lawyer, they're going to look at that and say you haven't done compressions, and it's literally that we're not documenting. So that's one thing that we really want you to get out of the class. When you hit start in your document, the next button you should be going to is code interventions and starting your compressions.
And you can back time all the code starts and code all that.
Mm-hmm. You can, well, I should say you can change the time in anything. To go back and change a time, so you can change the time in start, you can change the time in end. You can't, you would have to erase everything and start over in between. But it is doable, and yes, we do it all the time. And one of the things that we are missing is our every 2-minute pulse checks. So you call a code, you start compressions, within 2 minutes you have to do a pulse check. You do your pulse check, and we got to get right back on that chest. Okay. And I'm going to show you how to do it in the real world, in the playground in a second. Names. There's only 2 or 3 names that really need to go in the document. People get a little bit overwhelmed with this because they want to put everyone's name in, and that's not necessary. I'd much rather you spend the time doing compressions and doing your pulse checks and doing your medications versus putting names in. You need the doctor who's running the code. Who is the person running the code in a code situation? Because there's going to be 8 doctors in your room. And so as a documenter, this is something you can do that's going to really help out the room. When you get into the room and everyone's yelling orders, say, hey, who's running this code? Who's going to raise their hand? About 8 different doctors. So this is a perfect scenario where you can say, okay, 8 of you aren't running this code. And they're going to figure it out real quick who really is running the code. That gives you a doctor. It also lets everyone else in the room know who is truly running that code. Okay, so it's a really good thing that I like to do. So you need your doctor in there, that one doctor. They're usually going to have a red string around their neck that says code leader, but it's a learning institute, so we're going to get a lot of doctors in there. The other person is the nurse that's giving medications. It doesn't have to be everyone that's giving compressions. that's a nicety, but a have to have is your doctor and your nurse. You don't want to be writing that your nurse on 5-bed tower is giving medications when they're not ACLS certified. So make sure you've got that code nurse that's got the bag with them. And they're going to want to give you a name. They need to know that they're there. So make sure those are the 2 names. Respiratory therapy is great to have. However, a lot of times I know their first name and not their last. There is an add unknown button, and what it does is you can add that for your respiratory therapist. It's going to give them credit for being there. You're just not quite sure what their last name is. I can tell you a lot of their first names, but not their last. That does not work for your doctor or your nurse, because you need to be able to label them with someone. So this is when we're talking about that code interventions button. Every 2 minutes that we need to do a pulse check. So what this is this is a busy PowerPoint, but basically what it's saying is you open the code interventions button. This is the screen you're going to get. When we hit initiated, that starts our compressions. 2 minutes later, we're going to hit the stop button. Unfortunately, the Epic will not let us hit 2 buttons, but we want to know why we're stopping. So we're going to hit stopped, and then we're actually going to write in a comment. This is one of the few times we do write it in that says pulse check. Okay? We're going to do our pulse check. Within 10 seconds, we're going to try to get back into that, right back into that computer. So we're going to hit accept. After we do that pulse check, we're going to come literally right back in and reinitiate our compressions. So that should be done very quickly. Okay? It doesn't matter what happens. All you're documenting is that it's being done. Don't worry about what they're or what they find, if they're going to decide to do a defibrillation or if they're going to go back to CPR. Just make sure you know you're getting back on that chest. Unless they say, nope, we have a pulse, you need to get right back on the chest, because even if they're going to defibrillate, it's going to take a little bit of time for those to warm up. So we need to still get back on our chest. Okay? So again, I'm just going to say this again. Initiate is, hey, we're starting compressions. 2 minutes later, we're hitting stopped. At the same time, we're writing in pulse check. Hit accept. Go back right back in and initiate again. Every 2 minutes. Okay. When we shock, so we're still going to get right back on that chest while that defibrillator is warming up. If it's a shockable rhythm and that nurse says to you, we're in VFib, we're back on the chest, we're going to chart VFib, and then we're going to go in and do our joules. So when we hit accept, go back in to restart our compressions, you can put, there's only 2 shockable rhythms, VFib and pulseless VTAC. If someone wants to shock AFib, please tell them to not do that. Those are the only 2 shockable rhythms, pulseless VTAC and VFib. If we're going to shock them, the doctor's going to yell out, or the ICU nurse is going to say, how many joules are we shocking at? And then most of the time, they're going to say we're defibrillating during a code. And then we're going to hit accept, and then we're getting right back on that chest. It doesn't matter what when we shock, what the rhythm comes out to be. Unless that patient tells you to get off my chest, you're going to get back on that chest. And we're going to give them another 2 rounds and recheck again. So when our patient has return of spontaneous circulation, or ROSC, we need to document that again under code interventions. See how this is becoming the go-to button. When we do get to ROSC, we obviously aren't going to get compressions again. We're just going to find the rhythm that we're in, whether it's AFib, whether it's something with a pulse. We just need to make sure we're charting that rhythm, again under code interventions, that says there's a reason we're not getting back on the chest. Our outcome, another thing that we're missing a lot as far as documentation is concerned. our outcome is survived or not survived. Has anybody done, when you do a rapid, there's like a million different outcomes you can have. A code is they lived or they didn't live. It's pretty simple. And then the location they went to if they did survive. And then code end. Make sure you're hitting code end. If you don't hit the end button, what's going to happen is that chart is going to continue to run. So as long as your patient's in the hospital, they're going to continue to have everything that's documented, whether it is labs, whether it's doctor's orders, nursing note, is going to stay in this chart. Okay, so make sure you're hitting a code end when the nurse who's taking the patient with them leaves the room, that document can end. And that is it for that. So we'll read the document here, and then I want you to start actually doing your charting, and I'll walk around and help you through it. Okay. So you're in charge of one of your nurses presses the code blue button in room 12 and asks for help. Your HUC can call the code blue and get the two different, one wow, and there's one wow in the room. The patient's unresponsive, has no pulse. Your nurse has already started compressions. You open the chart and confirm it. Yeah, make sure it's the right patient, because if it's not, it's a lot of effort to try to go in and delete. Because remember I said everything spreads out to the real chart? So if you would cancel it out, you still have to go back to the real chart and cancel everything else out again. So you go to the documenter and start the code, go to code interventions and initiate compressions.